Good evening. Welcome, everybody. I am Vahe Bedelian. I'm a pediatric gastroenterologist at Children's National Hospital in Washington, D.C. And it is my pleasure and honor to welcome you all for today's webinar. We have our agenda here. I'll do the introductions of our speakers. We have a great group of speakers today who helped improve our understanding of celiac disease in underrepresented populations. Following the presentations, we will have a discussion. So please submit your questions so that we can address them at the end of the talk. And last but not the least, we'll have wonderful, exciting announcement about an upcoming grant opportunity. And my colleague, Vanessa Weisbrod, will talk about that. So our speakers today are Dr. Javier Villafuerte Galvez from Beth Israel Deaconess Medical Center, Dr. Haley Zilberberg from Columbia University Medical Center, and Dr. Amanda Carty from the University of Alabama Hospital Center. And without further ado, we'll start the talk of our first speaker.
All right. Well, thank you very much. It's a pleasure to be with all of you. Thank you all, for the invitation. I'm going to start with talking about the celiac disease in Latinos in the U.S. And I'm going to preface this saying, well, it's mostly about question. There's a concept that celiac disease may be rare or maybe missed or maybe different in Latinos. And I'm coming, from a place of curiosity and interest, not a place of great knowledge. I do have some, some clinical experience, but unlike my co-speakers, I have not been, well published in this area, and I'm still very honored to be here. So let's move forward. First, I wanted to start with an introduction. So when we talk about Latinos in the U.S., well, where do Latinos come from, and are the countries where they came from, or their ancestors came from, countries where there is a higher or lower seroprevalence of celiac disease. This is Prashant Singh's meta-analysis from 2018 here on the left, and he shows that the U.S. being kind of a third quartile higher prevalence, and looking at countries in Latin America, Mexico seems to have a higher prevalence, fourth quartile, and then the southern tip of South America countries like Brazil and Argentina having a 26 to 50th percentile, kind of a second quartile type of seroprevalence. Now, this study has all types of observational studies, including blood bank donor studies, actual probabilistic representative studies. So that's also a limitation. For instance, you can see that my home country of Peru shows as a lower seroprevalence country, like in the first quartile, and then when an actual probabilistic population-based study came out, it seems like it's in the same realm as the U.S. or Brazil, at a 1.2% seroprevalence. Now, seroprevalence, does it equal disease prevalence? We don't know. Another factor that has been brought up as a possibility of being a driver is the consumption of wheat, and it's often mentioned, but no clear correlations are drawn in what I've read, and you can see in the graph on the right, that the per capita wheat consumption in kilos from 2020 goes from this purple to yellow. And interestingly, the countries with the most wheat consumption, so Argentina and Chile, at least in seroprevalence, don't seem to be the highest countries. And you can find that a country that it has a higher seroprevalence, like Mexico, actually is a very low wheat consumer. It's a country that really eats more corn as its grain base. So this has been postulated as a potential driver, but it's not quite clear how it is, and there are more nuances about the type of wheat, but really not completely clear to me. So to summarize this initial slide, yes, well, where do Latinos come from? From South America, Caribbean, and North America. And there's a whole variety, but it doesn't seem to be an area of exceptionally low seroprevalence or exceptionally low consumption of wheat, which may be drivers of the prevalence in the Latinos in the U.S. Then comes another paper from the N. Haynes in 2009 and 2010. Again, these are very small numbers, so it's we've got to be very cautious to draw any conclusions, but they make estimations of prevalences, mostly based on serologic and also surveys where they ask whether you've been diagnosed with celiac disease or are on a gluten-free diet. They make an estimation that is supposed to be probabilistic and well representative. Non-Hispanic whites around 1%, which is around what we think it is, around 1.4%. But then in people of Mexican origin or other Hispanic origin, they do find very low seroprevalences. But then again, it's in the single digits. So how representative it gets to be at that subgroup level, not completely clear. And one interesting thing, though, that they do find is that they see seroconcordance between TTG-IgA and EMAs to be lower in the non-white population, and this is probably the same from the biological point of view. A weakly positive TTG-IgA, as TTG is still the antigen in EMA, more common in non-white populations. But it is an interesting finding, and that will be reflected in some other studies later. Finally, so I think I did see Ben Lebwohl in the audience. He's one of the senior authors in this one, but this is a study that was done that was published in 2016 I found very interesting. So it is a large US reference pathology lab used as the data source. They did something I never thought was possible, but it was they identified race and ethnicity based on a validated algorithm based on the names of people, which I mean, I've always wondered, wow, is that valid? But it's looking at references, it seems like it has been validated in different forms. So this is very interesting. For the table, the reference category will be including both non-Hispanic white and Black patients, because there's no way to tell based on the names. And one of the strengths of this paper is it's probably in the US at least, is the one with the largest quantity of Hispanic Latino patients, about 31,000 duodenal biopsies, so around 7% of the full sample. And this allows to make a robust estimate, of course, different populations because they have higher suspicion, but of a prevalence of 1.06%, and calculated the confidence interval on my own, but it's, as you can see, it's much more narrow compared to the NHANES data, 0.95 to 1.18. So a very interesting estimate. Still significantly lower than the reference category, even adjusting for age, gender, and H. pylori status. Similarly lower in East Asian patients, but well, definitely much lower. So that's another cue to thinking, well, probably not, maybe a little less common than in the general population, but not terribly uncommon. This is data I pulled over the weekend from BIDMC. We implemented ICD-10 in 2015. So this is basically I pulled every patient who had at least 3 outpatient visits with a celiac disease ICD-10 code K90.0. So the total is 1,488, and then we could stratify them by race, ethnicity. There is some missing data, unknown or declined to provide around 5%. Then others when the numbers are too small, but at least in the patients that have been seen as outpatients at BIDMC with a consistent use of the diagnosis of celiac disease, 86.3% are white, and Latinos only represent 2.8%, and followed by Asians and Black patients. Now, question is, well, does this represent just the catchment population of BIDMC, or does it represent? Does it tell us something about how common this disease may be in these different ethnic racial groups? So what I did is I performed the same search, but for all outpatient visits, and this is in around 900,000 total outpatient visits over the same period. And you can see that there's a striking difference in so of all outpatients seen at BIDMC, it's not 86% that are non-Hispanic white, but 51.1%, showing definitely a catchment that is a lot more diverse than our celiac catchment. And you can see that 5.8% of patients are classified as Latino, Hispanic, compared to 2.8 in celiac disease. And you can see these gaps that are different for ethnic groups. So for Latinos, around 2 to 1. For Asians, around 7 to 1, and for Black patients, around 9 to 1. So the question is, well, is this a gap in catchment? Is it self-selected? Is it also less common? Not completely clear, but we can say that we have a less diverse catchment population in the celiac clinic compared to all outpatients at BIDMC. The next few slides, what I wanted to do is this kind of like the end of my data part of this. So I wanted to share a few clinical vignettes of patients I've seen over the years, and I wanted to be very honest about our victories and our losses, because I think this is part of how we will. I think it's good to grow. Start with someone who I consider a victory. This is not someone this is a patient that I saw as a fellow and then has continued with another celiac doc. She's 53 years old, originally from Guatemala, speaks only Spanish, and she was referred in the setting of a TTGIG of only 2 times the upper limit of normal, and in the context of an ALT in the 300s. She already came with a fibroscan with us in the fibrosis range, and had a liver biopsy with NASH cirrhosis. She had an EGD with a duodenal biopsy March 3. So I saw her at least 4 or 5 times when I was a fellow, both in the liver clinic and in the celiac clinic. And it really took us about 5 years for her to seronormalize. I actually caught back about her recently, because I was helping Melinda translate a letter, and the barriers for her initially were, first of all, understanding the disease. I mean, she was diagnosed with 2 major diseases. One of them was NASH cirrhosis, and celiac disease. So, understanding how well you need to lose weight, eat less calories, but also at the same time eat without gluten, the concept of gluten as a protein in wheat, barley, and rye took a lot of work, both on my side and Melinda, who has been following her for a lot longer. And one of the main barriers was that this lady was a very good baker and cook, and she had a love for sweet bread, and it took her a lot of difficulty to stop eating sweet bread. So those were the barriers for her, but ultimately she's now zero normalized and doing much better. I mean, someone diagnosed with cirrhosis that is okay 5 years later, I think is a huge win. Next one is a patient I've also managed with Melinda Dennis. He's originally from Brazil, Portuguese speaking. He's a personal trainer and boxing coach. He came to my liver colleagues with an ALT in the 400s, was diagnosed with primary sclerosing cholangitis, autoimmune hepatitis, overlap, and cirrhosis, but was also having diarrhea and was found to have a TTG 4 times the upper limit of normal. My liver colleague, does some counseling and asks him to avoid gluten, and he avoids gluten for a month, and then, despite all the avoidance, his TTG goes up to 9 times the upper limit of normal over the course of 1 month. So that's when he's referred to me. I scope him because it was like, wow, I wonder if this is really celiac disease, and it was. He did have a March 3C biopsy, and over the last 12 months, mostly following with my liver colleague. He has, it takes a lot to have him follow with 2 specialists, but he has been following with Melinda for the dietary counseling, and his TTG is down to 2 times the upper limit of normal, no longer having diarrhea. And the barrier that we found was that he was using protein powders at the gym that likely contained gluten. Of course, we could never prove it, but I think that's what really made the difference when his serology started to come down, was when he stopped doing those, and our counseling was, just eat tuna, eat some other form of protein before working up. So this was another win. And now I'm gonna tell you about 2. This is probably more common of a situation, unfortunately. These 2 failures in our care. First one is a 59-year-old lady originally from Venezuela. She speaks Spanish. She gets an open access EGD for epigastric pain and dyspepsia with one of my colleagues. She's positive for H. pylori, but her duodenum did look atrophic, so she gets duodenal biopsies, and she's March 3 from D1 through D3. The fellow that had scoped her gets serologies, which apparently took a lot of insistence, and she did have a TTGIG at 2 times the upper limit of normal, total DGP back when we didn't do the separate IgA IgG of 2.5 times the upper limit of normal. But she comes and sees me in clinic. I explain everything, but after this, she missed her appointment with Melinda. no follow-up, multiple phone calls, letters, and she never followed up. So we don't really know if she went gluten-free or not. The other one was shorter story, but just as dramatic. I really hope she's doing well. But a 23-year-old Mexican-American student, originally from Texas, who's an urgent care referral from the Chelsea urgent care. She comes with nausea, diarrhea, and a 15-pound weight loss over 3 months. My initial lab work on the day of visit comes back with iron deficiency anemia, an ALT 3 times over the limit of normal, and a TTG-IgA came back a week later, 10 times above the upper limit of normal. And unfortunately, she did not. She was in a college campus, called, never found her, sent letters. She had no PCP in the system, and really never showed up. I tried the magic buttons to find if she went to another of the centers locally, but so these two cases, show us how some patients we really cannot keep in the system and capture. And I don't know exactly how to improve that part. I don't want to finish on a negative note, so I have the last two vignettes. A 64-year-old lady from originally from Brazil, English speaking. Her daughter with type 1 diabetes and celiac disease, but she comes referred for GERD and IBS-D. She tells me that she's had iron deficiency anemia for as long as she knows. And somehow, like, having a relative with celiac disease didn't trigger the thought. So we check her TTG-IgA. She's at 5.5 times the upper limit of normal. We scope her and we confirm the diagnosis. As she starts avoiding gluten, her GERD symptoms and quote-unquote IBS symptoms get better, although she still is on supplementation, but a lower dose. She's at 1.5 times the upper limit of normal after 12 months. So that's another one. I think in her case, it's a win. It's still working on it, but last one has no resolution yet, but it's a 32-year-old man from originally from Puerto Rico, English speaking, is referred to me by one of my IBD colleagues. He has stricturing ileal Crohn's, initially on adalimumab, now on risankizumab. He got a TTG in the context of an ALT of 1.5 times the upper limit of normal. So really low threshold to check a TTG for normal FTs in this case, but TTG was 1.1 and then 1.5 times the upper limit of normal. He's heterozygous for DQ 2.5. He got scoped, and in the bulb he had some evidence of peptic duodenitis, but maybe some patchy villus shortening, and in D2 some patch increase in IELs. My IBD colleague did not recommend to go on a gluten-free diet and recommended, to see me in consultation, but he, of course, was a bit scared and decided to do a gluten-free diet on his own, after which his TTGIG was less than 1. I saw him yesterday, actually, and we're planning for a gluten challenge. He was actually surprised that he may not have celiac disease, and he's very excited about the possibility of ruling it out or in, because it's been hard for him to do the diet. So hope that with the vignettes I gave you a small taste of some of what my practices and some of the challenges. I'll move to the take-home points. I still have more questions than answers on this subject. I think that if celiac disease, if truly less common in Latinos, is probably not uncommon at all. Though there's likely a gap in testing, diagnosis, and access. Are there lower TTG-IgA levels, like what Dr. Mendekarty has shown in Black patients? That's an interesting question, but looking at our previous databases, most people are in the 3 to 4 times the upper limit of normal upon diagnosis, and not at the over 10. So perhaps not that different. Challenges. What I do see is that there's often less disease awareness in Latino population. Sometimes there are more profound knowledge gaps, like in the first patient I discussed with you, and of course different eating habits, preferences, and culture. You know, our dietitians have, Melinda has done an amazing effort to accommodate to these patients, and of course the language barriers, and also the communication barriers that may arise and may not allow us to keep these patients in the system. I think that will be all for me, and thank you again for listening, and looking forward to the discussion.
Thank you very much, Dr. Villafuerte Galvez. Wonderful presentation. Yeah, this kind of issues always come up when we do clinics with the fellows, and discussing who to test for celiac and who not to test, depending on the race. And it's the patterns that you showed from your institution are probably the same for our institutions as well, but it's still striking to see how big is that discrepancy between the percentages of different groups seen in the general clinic versus celiac clinic. So really great talk. So I'll move forward now, and again offer the floor to Dr. Haley Zilberberg. Dr. Zilberberg, let's go ahead.
Okay, so I just shared my screen. Hopefully you can all see it. Hi everyone, I'm Haley Zilberberg. I'm a third-year GI fellow at Columbia, and thank you so much for having me here as part of this webinar today. So I'll jump right in. Today I'll be talking about our recent study that was done at by us at the Columbia Celiac Disease Center, along with in partnership with Beyond Celiac Disease. It's called Correlations Between Relative Prevalence of Celiac Disease and Sociodemographic Variables in the United States. And it was available online this past October, and is soon to be in print. And for those who are interested in learning more, there's a QR code that you can use. Okay, so I'll start off with some background. We already know that celiac disease is pretty common in the United States, with a prevalence of 0.8%. This number is taken from a study, looking at NHANES, so it's zero prevalence. We also know that the diagnosis has increased over time, but despite this, many patients, many people still really remain undiagnosed. And there are many reasons why this could be. Is it that they're asymptomatic? Is there a lack of awareness by practitioners, or is there under recognition in certain populations? And that's sort of the aspect that we wanted to focus on in this study. So the aim of our study was to evaluate associations between celiac disease prevalence and sociodemographic variables at the zip code level. And so, talking about our method, so this is a retrospective study, and it is on the population level. So we really looked at celiac disease by zip code in the United States and not on the individual level. And so, that needs to be kept in mind as we move on and talk about the results in a little bit. And so, to do this study, first we needed to identify patients with celiac disease. And we did this by using a US Medicare fee-for-service claims registry that was developed in partnership by the National Minority Quality Forum and Beyond Celiac Disease. And this registry included patients from 2016 only. And we identified celiac disease specifically by ICD-10 code. And because this data, was de-identified, we only had patients at the 3-digit zip code level, and again, not on the individual level. And so our outcome of interest was prevalence of celiac disease per 3-digit zip code, which we defined as the number of patients with celiac disease out of the total number of Medicare fee-for-service beneficiaries who had at least one claim in 2016. So in terms of the variables that we included, we looked at income, race, ethnicity, urban area, social deprivation index or SDI score, and proximity to a celiac disease center. So all the variables apart from proximity to a celiac disease center, so income, race, ethnicity, SDI score, and urban area, were all taken from the US Census data, specifically in 2016. And the way that the US Census reports these data is on the 5-digit zip code level. And so we needed to sort of coalesce each individual variable in order to make it sort of on the larger 3-digit zip codes. And for those who are sort of unfamiliar with how these zip codes work, the first 3 digits of a zip code sort of encompass a larger area that includes multiple of the 5-digit zip codes. And so it's a little bit of a larger area than just the 5 digits. And another thing to note as we move on and shortly talk about the results is that the higher the SDI score, the greater degree of social deprivation. And then our last variable was, binary variable, whether someone was in close proximity to a celiac disease center. And we, in order to identify the centers, we used the SSCD's unit recognition program that included 6 centers across the country. And then we identified the 3-digit zip codes within 100 miles of the center. And we sort of said those were zip codes that were close enough that we'll consider to be, in proximity to the center. So in terms of our statistical analysis, we reported these descriptive statistics in each celiac disease prevalence quartile per 3-digit zip code. And then we used linear regression models to evaluate associations between prevalence of celiac disease per 3-digit zip code and all the socio-demographic variables that I mentioned. We first looked at each variable individually, and then we looked at a model that combined all of the variables together. And so now I'll jump into the results. And so this slide, this figure is a map of the United States, and it's a heat map. So you can see the prevalence of celiac disease, across the different states and sort of by zip code, 3-digit zip code. And the areas in yellow have less celiac disease, and the areas in red have more celiac disease. And again, this doesn't encompass, all of the United States, all the people in the United States. It's only a Medicare beneficiary, of a specific year. So it's not sort of the true prevalence, but we do begin to sort of see, various patterns that emerge. In all, we identified 70,000 patients with celiac disease among, a large registry, and our total prevalence in the registry was 0.18%. And again, this number is lower than sort of what we expect to be the national prevalence, but again, it's a sort of a small subset of patients here, and the prevalence really varied from 0.02%, which is the lowest, which was in Puerto Rico, to the highest, which was in New York at 0.95%. So this is table 1 of our study. And here we divided celiac disease into the celiac disease prevalence into 4 quartiles, from lowest, quartile 1, to highest, quartile 4. And then we looked at each of these socio-demographic variables by quartile. And we can really begin to see some trends emerge here. And so you can see that as the celiac disease prevalence increases, some variables decrease. So notably, if you look at the percentage of Black individuals, this decreases from 13% to 8%. The percentage of Latino Hispanic individuals decreases from 88% down to 13%. And the median SDI score decreases from 55 to 29. And remember, I had mentioned that the SDI score is social deprivation, meaning that the lower the score, the lower the social deprivation. And you can also see that as celiac disease prevalence increases, so from quartile 1 to quartile 4, you can see that other variables increase. So notably median income increases, proximity to a celiac disease center increases, and urban area increases as well. Specifically in terms of the percentage of Asian race, there really isn't hard to sort of make out any sort of difference across the quartiles here. And in this figure, what we did is we showed the each continuous variable in the study graphically. And so, if you take a look here, so panel A looks at celiac disease prevalence by Asian race, and you can see that it's sort of pretty steady, hard to really see any sort of pattern. But in panel B, we see the celiac disease prevalence by percentage of Black patients or people in this area. And you can see that there is sort of like a downward curve, that there is this sort of negative trend. Similarly, in panel C, you can also see this negative, downward slope, for, as celiac disease prevalence increases, the percentage of Latino Hispanic participants sort of decrease. And then in panel D, we looked at median income. Here you see sort of a positive correlation as both the celiac disease prevalence increases, the median income also increases. And then in panel E, here we show the median SDI score. And as the celiac disease prevalence increases, the social deprivation decreases. And so now this is the table 2 of our study, and we show the results of our linear regression model. And here we looked at the association between celiac disease relative prevalence per 10,000 people per 3-digit zip code, and that association with the sociodemographic variables. And so part A is each variable in a separate model, so alone. And again, we really see these patterns again. So we see a negative association between celiac disease prevalence and Black race, Latino Hispanic ethnicity, and median SDI score. And these are all statistically significant. And we see that positive association with median income, proximity to a celiac disease center, and urban area. Again, all statistically significant. And then in part B, we put all of these variables into one model. And again, all the same associations still stand. All these variables are still statistically significant. And what we were able to do, in this analysis is, we found that about 30% of the variation in celiac disease relative prevalence in this data can be explained by our variables. So not all of the differences across areas, but at least in part can be explained by these sociodemographic variables. And so to wrap this up, in conclusion, at the geographic level, celiac disease relative prevalence was positively correlated with median income, urban residence, and proximity to a celiac disease center, but negatively correlated with median SDI score and percent of population of Black race and Latino and Hispanic ethnicity. And the reasons for these variables, are not totally clear, right? This is not on the individual level, it is on the population level. But they do suggest that disparities in healthcare may contribute to the underdiagnosis of celiac disease. And, it is, of course, it's possible, that people who are of Black race or Latino and Hispanic ethnicity, it is definitely possible that they just do manifest celiac disease sort of differently. They don't have celiac disease as frequently, as commonly, and that's definitely possible. But it's looking at this data, income shouldn't really be associated with more celiac disease. Living near a celiac disease center shouldn't really be associated with more celiac disease, and especially social deprivation. As there's sort of less social deprivation, there's sort of an increasing diagnosis of celiac disease. I think all of these things do suggest that there's something else here, and it definitely could be that there are disparities, whether it's in how we think about celiac disease, maybe we don't test for it, whether these people don't have access to the right providers, or whether, and I'm sure we'll hear about this more in a little bit in Dr. Carti's talk, but about could there be differences in how the disease manifests in these different populations, and are we using the right tests for them? And with that, thank you everyone for listening. Thank you to, especially to my mentor, Ben Lebwell at the Celiac Disease Center at Columbia. And thanks for having me here today.
Thank you, Dr. Zilberberg, and wonderful presentation, and congratulations on the paper. I look forward to reading it. There's definitely a lot of data to process, but I certainly underscores the endemic issue of disparities when it comes to celiac disease. So with that, we'll move on to our last speaker, and Dr. Amanda Carty, the floor is yours. Thank you.
Great, thank you. Let me share my screen. Okay, and I hope everyone can see everything.
Thank you for the invitation
Oh.
to speak about celiac disease and
You know, I'm sorry. I actually had recorded this, and I wonder if it'll let me just go through the slides. I might have to delete the recording. I'm sorry. I came from another meeting, so I had to, I had meetings back to back. There we go. That's always better live. Okay, that's better. Well, thanks again for the invitation. I'm really excited to be here this evening to talk about celiac disease in Black Americans. So first of all, our objectives here, we'll talk about the prevalence data on celiac disease in Americans, Black Americans, and identify knowledge gaps and how we can apply this to our current data. As you know, the current clinical dogma is that celiac disease is rare in Blacks. And so we're going to talk a little bit about why this might be the clinical dogma and how we can address it. As you all know, there's a genetic component to the development of celiac disease, and this is DQ2, DQ8. And these regions of the HLA are actually very highly conserved within a population. And it was actually HLA haplotyping that was initially used to help inform a person's ancestry and their relatives. And we know from the past that we thought celiac disease primarily affects people with Northern European ancestry. But we know, according to literature over the past decade, this is not the case, and it can occur in people of various ancestral origins. So this really brings us to the question of, does celiac disease occur in Blacks? And that's what we're going to be talking about for the next few minutes. This is the limited data that we have on celiac disease prevalence in Blacks, as well as the clinical characteristics. As of 2022, this was all the data we had. So the initial study out of Colombia with biopsy-proven celiac disease, 9 out of 700 had self-identified as Black. This is the only study with the clinical characteristics of celiac disease in Blacks. A US military study showed about 3% of patients in the cohort self-identified as Black. And then we really get to these last 3 studies here that are all NHANES studies, US population-based studies. They took a history of celiac disease on a diet with a combination of serologies to determine who had celiac disease. Unfortunately, these were all underpowered to really determine the true prevalence of celiac disease in US minorities. So this is one of the reasons I moved to Birmingham in 2021. Birmingham, Alabama is in the deep South, outlined here in green, if you're not familiar with this area of the United States. And UAB has a very diverse patient referral base that pulls from 5 states. It's diverse in race, socioeconomic status, where patients live, urban, suburban, and rural, as well as their payer status. And one of the unique things is really the demographics of Alabama compared to the rest of the United States. Even though that this is a small state of about 5,000, more than 25% of Alabamians self-identify as Black, which is more than twice the average in the US. And so when I came to UAB, one of the first things we did was develop a celiac disease registry. And the goal was to have a very sensitive case identification. So we took anyone with a billing code over a 10-year time frame, and that yielded about 2,500 patients. We went through those by hand to determine who actually met inclusion criteria. and excluded about 60%. Of the 852 patients with possible celiac disease, nearly 5% self-identified as Black. Within that group, we really subcategorized them based off their likelihood of having celiac disease based off the information we had in the chart. And this really led to three findings. Blacks were more likely to be obese than non-Hispanic whites at diagnosis. Only 50% of people in our registry were diagnosed with both serologies and biopsies, which has been the current clinical guidelines for a while. And then lastly, Blacks with biopsies consistent with celiac disease, villus atrophy, increased IELs, were more likely to have negative serologies. And so we're looking at this also within our partner networks in the Deep South, called the CCTS. We have 11 sites in the Deep South, and we're currently collaborating with one of them, Tulane, and they have looked at billing codes over the past 10 years, and about 11% of those patients self-identified as Black. I suspect that there's a strong degree of miscoding, probably about 60%, as we saw in the UAB cohort. We still need to go through those by hand and look at clinical characteristics. So that leads us to the conclusion that the prevalence and clinical characteristics of celiac disease in Blacks remain largely unknown. So how can we do that, and why do we have these limitations? Well, there's probably lots of reasons, but I'm really going to highlight three here: the genetics, clinical reasoning, and our cognitive biases, and even issues within the healthcare system. The first is the genetic knowledge gaps. We do have prevalence data from the continent of Africa, although it's limited. And as you can see in the map here in the upper right, these are the studies. And really the take-home point is that there's a wide range of seropositivity from 0 to the highest in the world. There's variable rates of permissive haplotypes. So there's really just heterogeneity, which I think we can all appreciate in celiac disease across the world. One of the other environmental factors to consider is that the gluten exposure might be different in Africa compared to other continents, and even just in the continent at all. So teff is the primary grain in much of Africa. Genetic ancestry may also impact celiac disease risk and development through non-celiac HLA haplotypes or non-HLA genes. The best example I have of this is of type 1 diabetes. They took a cohort in Oakland, California, and divided their patients with type 1 diabetes into two groups based off race, white and Black. The HLA haplotype that was known to increase risk of type 1 diabetes was actually protective in Blacks. And the reverse was also found to be true, where the haplotype that increased in Blacks actually had a lower risk in the white cohort. And there's also this question of genetic admixture in the United States, which is common. We really don't know how that impacts celiac disease risk. So we've done a little bit of work on HLA haplotyping in celiac disease and potential celiac disease at UAB. A little bit of background is that our HLA laboratory is the only accredited HLA laboratory in the state. And because of that, they perform all the haplotyping for transplants performed at UAB, UAB Callahan Eye Center, Children's of Alabama, and the VA. This is more than 14,000 tests annually. And as another aside, our Comprehensive Transplant Institute performs more kidney transplants in Blacks than any other center in the United States. So we looked at the allelic frequency of DQ2 and DQ8 in whites and Blacks. And in this pie chart on the top right, you can see that DQ2 is similar between the two groups, and DQ8 is greater in whites than Blacks, which we know that DQ8 has a role in celiac disease, but the higher risk allele is actually DQ2. And then in the table here in the lower right, you can see the dosing effect of DQ2 and DQ8. So this really leads to some potential clinical reasoning and cognitive biases, where if we start at the top with our clinical dogma that celiac disease is rare in Blacks, we may not even think of it in a differential diagnosis. And if we don't think of it, we're not going to test for it. which yields misdiagnosis or misdiagnostic opportunity. Some of these patients might actually seek information elsewhere and even adjust their diets on their own, which again makes it harder for us to diagnose celiac disease. So confirmation bias leads to misdiagnostic opportunities. The healthcare system might also contribute. This is a map from the AMA showing physicians per 100,000 people. And you can tell in the dark blue, that's the areas where there's more doctors per 100,000 people. And here in the teal, in the south, you can see there are less physicians per 100,000 people. This is true for both primary care and subspecialty care. And I can say I can definitely feel this in my clinical practice compared to the states I've worked in, which are purple, Missouri, Minnesota, and Michigan, compared to Alabama, which is in teal. And so unfortunately, when there are these types of ratios where there's not enough physicians, it increases the wait time, which can lead to higher no-show rates, which basically makes for an inefficient clinic. And it really might even spur providers and even patients to think, is this appointment even necessary? I already know I need to go on a gluten-free diet, or maybe my symptoms aren't that severe. Maybe some of them are subclinical. It also brings in the question about transportation and travel distance to see a doctor who specializes in gastroenterology. Let's take a closer look in the state of Alabama. So you'll see this is a map of Alabama by county, and every area shaded in red is actually a medically underserved area according to federal guidelines. So you can see much of the state is actually medically underserved, with the exception of where UAB is located in the middle. Another component to the healthcare system is that in some communities of color, there may be significant mistrust for a variety of reasons. In the Black community, I think history really points to the Tuskegee syphilis experiment, which went on for 40 years, during which time penicillin became clear as a necessary treatment. But unfortunately, study participants were not even offered this treatment. So huge ethical violation. I think we can all understand why there would be mistrust in this community of the medical community. And so we've really reviewed here 3 different categories of why we have limited data: genetics and how ancestry might impact celiac disease risk and development, our own clinical reasoning and cognitive biases, thinking about how we can reduce this in clinical practice, and particularly in providers who might be the first line of testing for celiac disease. And then issues within our own healthcare system. I think we've always thought about, how can we reach people with undiagnosed celiac disease? But I think when we're talking about communities of color, there's a lot of different layers that we need to think about. So in summary, the prevalence of celiac disease in Black Americans is unknown due to limited data. And it actually might even be underdiagnosed in Blacks for a variety of reasons. We don't know much about genetic ancestry. There might be cognitive bias and issues within the health system. And I think we can all appreciate from all these talks, it will take a multifaceted approach to help determine the actual prevalence of celiac disease in these communities. Great. So I'm sorry my slides were a little off.
Thank you.
But
Thank you.
I'm sure we'll have time to talk.
Thank you very much, Dr. Carty. Very wonderful presentation. Issue of access is a bane of our existence as well, as I'm sure it's everywhere. So we have time for some questions and comments. Dr. Benjamin Lepol commented earlier on Dr. Villafuerte Galvez's talk, saying, striking how so many of these patients have additional GI conditions at the time of their celiac diagnosis, all these autoimmune conditions, Crohn's, PSC, and others. I was curious, Dr. Villafuerte Galvez, when you describe the discrepancies in seropositivity in, let's say, Mexico versus Argentina, which didn't really match their wheat consumption, would there be any possibility that maybe the HLA haplotypes are significantly different between the two countries, or maybe there's some other factor inside of that?
I don't know too well about Mexico. I know that there's one study in Argentina, pediatric population, and they show that there's a significant amount of both DQ2 and DQ8. Even and they even checked for mitochondrial markers of native ancestry. So people who had those markers still had DQ2 and DQ8. So maybe not the HLA. One of the seroprevalence, different countries, Mexico is that seroprevalence is mostly based on a blood bank donor study in Mexico City, which may not represent all of Mexico, right? So that's something to remember. A few places have like population-based studies, like the one that happened in Peru. Actually, that was good luck. They took advantage of an STD database, serum base.
Good. And I see that Ritu Verma raised her hand. So can we let her talk? Okay, perfect.
Thank you. Appreciate that. Excellent talks. And I agree with the comments in the chat about increasing the awareness and for all of us to cut out some of the bias. The question I have is for Dr. Carty. You mentioned about the seronegative serology that you're seeing in the African Americans, the Black African Americans. What's the prevalence incidence? I know we've looked at our population here at the University of Chicago, looking at the children who have type 1 diabetes and looking at across ethnic backgrounds, and the testing has been done. So we have a number of African Americans who have diabetes, and they've all been screened for celiac disease. But of course, we have not done biopsies because they're seronegative and asymptomatic. So that comment that you made about the seronegative now makes me feel like I need to go scope all of those seronegative people. Make somebody happy, but how often do you see that?
I think the hard thing about this question is that the data that I presented this on is retrospective data, right? So it's limited to different providers might have had different differential diagnoses, different timelines, and people could have even had a delay from the time of, objective data. They could have had the endoscopy first and the serologies later. So I think it's interesting that that group was higher, but I think that I wouldn't put much conclusion on it at this point. I think it needs something that needs further evaluation. And I'm not necessarily saying that we need to go and do an endoscopy on our Black patients, but I think it should make us think about, are we actually testing or not testing someone because of the race that we think they identify with, because we may not know their whole story. And if they have things like iron deficiency anemia and weight loss, which really should prompt an upper endoscopy anyways, and probably biopsies along with that. I think that's the important piece at this point. And that we really need to collect prospective data to help answer that question.
Thank you.
There's a question in the chat. How do we get more doctors to acknowledge their unconscious bias and start testing regardless of race? I think for me, it was more education personally. I'm not sure if the speakers have any thoughts on that.
I mean, I do have a couple thoughts. I remember when I was at the University of Michigan and we were seeing a Black patient, and I said, well, all the symptoms that we would test a white person for celiac disease for. And I think I actually got some pushback from the fellow for testing it all. And it did come back negative. And I think that is the thing. They said, well, but it came back negative. And it's, we've tested one person, right? We don't know what the prevalence is. And I think it's important for us, again, not to put people in a certain category because we may not know their ancestry or their complete ancestral picture. And we don't really know what the prevalence is in some US minority groups. The other thing that I think is important, I think, is in starting it in medical school. I mean, I think most of us can think back how we were taught about celiac disease in medical school, and probably most of those things we've debunked over the past 10 to 20 years. So I think it's really good to start from the beginning, that we should think about there might be certain groups who just aren't being tested. I know here I help in the med school, and I definitely teach them that people of various ancestral origins can have celiac disease, but that may not be the same everywhere.
I have one quick question that links the difficulty for follow-up, the Medicare data and your data, Amanda. Do we know if Medicare covers the TTG in every state in the United States, or does it come with a bill at some point for the patient when we screen them, and then it's a deterrent for coming back because they received a bill?
I don't know what the copays are, and it might depend on the type of coverage.
But for Medicare, like people that are Medicare, Medicaid, the endoscopy is covered if deemed medically necessary, but are the TTG covered, or are they getting billed when we do that?
I'm not sure.
If someone in the audience has the...
I think there's a difference between Medicares too, right? Like there's a full-on Medicare that usually covers everything if the code is appropriate. And then there's the Medicare Advantages, which are very, very spotty in their coverage, and those are not necessarily the same. But definitely for Medicare, you need to have the right code for coverage, and the system, reminds you sometimes that that's not a proper code for this or that test. But I think it's very variable. It's unfortunately.
So it's 9:03 now, and Vanessa has some exciting news to share about the grant opportunity.
Thanks, Vahe. So we're really excited tonight to announce a new grant that's going to be available to SSCD members. This is in partnership with the Celiac Disease Foundation, a new grant, Improving Health Equity in Celiac Disease Through Disparities Research. This is going to be a grant of up to $100,000 offered up to over a 2-year period to support research initiatives aimed at understanding all of the things that we've talked about tonight. I know that the 3 speakers have done such an amazing job investigating in this area, and we want to continue supporting work along these lines. So we're really excited to announce the grant. There'll be an email going out to all SSCD members tomorrow with the application link, or you can use the QR code that's on the screen now. And the deadline to apply is August 30th. So you have a bit of time to get those applications in, but we really hope that there'll be lots of them and that there'll be some great research that will come out of this SSCD award. Also, Dr. Verma and I are really excited to talk about the new SSCD Health Equity Council that's really committed to promoting health equity to make sure that all of these patients are getting the right care and diagnosed appropriately. So the first project for the SSCD Council is going to be providing feedback on the draft guidance from the FDA on the collection of race and ethnicity data in clinical trials and studies. And so there have already been some of you who've reached out from the Executive Council to be involved, and we hope that many other SSCD members will join this SSCD group. So if you're interested, please use the SSCD email that is up on the screen, sscd@celiac.org, to join. And we truly hope that lots of you will want to get involved in this project. So I'm now going to turn it over to Catherine for the closing.
All right, so just a few closing remarks. So just a reminder that there's a college summit Thursday, April 4th at 7 p.m. Eastern, and this is geared towards rising college students or current college students with a diagnosis of celiac disease. So this is open to our patients. Just a reminder that most webinars are recorded and posted on the website for members. And to make sure to stay up to date on everything, visit the website. Special thank you to the rest of our webinar committee, especially Emily and Vanessa, for ushering us newbies in tonight. All of our fantastic presenters and our SSCD council as well. And just a last reminder to renew your membership. So all of these webinars are available for our members, and in addition to all the other fantastic things that we offer. Thanks, everyone. Take care. Have a wonderful night.